Well, PK, thank you for the invitation. I don't know how I got on a panel with three guys from the Midwest, but it's good here. So I'm Matt Bunte. I'm out of Kansas City. These are my disclosures. So, of course, this case is showing us everything we need to know, but there are many challenges that relate to stent choice and, the stent types and technique and how that stent is going to be deployed are all important considerations. So I'll discuss my algorithm for stent choice, which I think is being echoed here all afternoon. So really the goal of our iliac artery revascularization is durable relief of arterial insufficiency. Many times it's claudication, although certainly critical limb ischemia. Sometimes it's for passing large bore devices through the iliacs. But of course, we're doing this also to avoid artery rupture and prevent atheroembolism at the same time. And there are complexities for sure that we have to be always have our head on a swivel and ready to deal with. There's technical complexity with the cases we've seen this afternoon around the aortoiliac bifurcation and concomitant aortic disease. Certainly risk of perforation is always ever present in these interventions. Iliac tortuosity, calcification, in-stent restenosis, embolization risk associated with that, and runoff disease we have addressed. So while endovascular certainly is continuing to gain more and more momentum, there's probably still a role for surgery, and I think it's just important to keep in mind what the risks of the surgical techniques that are available in light of the endovascular treatments. And so this is just kind of a summary, considering endovascular stenting, kind of on the bottom row, looking at aortobifemoral bypass, AXFEM bypass, FEMFEM bypass, acknowledging that the AXFEM and FEMFEM populations probably are a little selected and probably a sicker population. All of these treatments hold up pretty well, so then it kind of comes down to tolerance for surgical risk and immediate complications, as well as mortality risk. And so most of the patients that undergo stenting nowadays are probably a little lower risk than going to surgery, given the stent options we have. So we essentially have two types of stent, balloon expandable and self-expanding. Really the balloon expandables are mostly cobalt chromium, and the covered stents we use are the iCast, VBX, and LifeStream is now available, but the VBX is a little different in that it's a series of rings, which makes it a little more deliverable, and that's what we've been discussing. The iCast has got 2 layers of PTFE, which essentially has some advantages. The self-expanding stents are made of nitinol and are also covered with PTFE for covering lesions. So when I'm considering using balloon expandable or self-expanding stents, there's multiple factors that go into the choice, and a lot of it's got to do with the anatomic location and the need to be accurate with deployment, particularly around the common iliac artery, where balloon expandable stents are generally favored. Radial force, as we've just been talking about with these calcified lesions, is a little bit better, probably with balloon expandable stents. And the downside, of course, is that they can foreshorten when they're post-dilated. The self-expanding stents, however, have really good patency data, and we'll go through a little bit of that. So the ICE trial was randomized, really the only large randomized study of balloon expandable self-expanding stents for iliac disease, 660 patients with claudication, disease isolated to the common and external iliac arteries, 1-to-1 randomization scheme, 18 centers outside the US. 60% of these were common iliac, 17% CTOs, a quarter were severely calcified, and no difference in periprocedural complications. As Dr. Croissant mentioned, self-expanding stents actually had a lower rate of binary restenosis and better primary patency. Freedom from TLR was also a bit better. COBEST, we've talked a lot about this afternoon, just wanted to mention it in context of this talk. I think it's already been noted that balloon expandable covered stents versus balloon expandable stents reduce the risk of binary restenosis at 18 months, and then post-hoc analyses, most of that benefit was in the more complicated lesions like the case we're looking at right now. At 5 years, the patency benefit was sustained with the covered stent. I really love this document. It was very thoughtful and has been a great resource for me in my practice, and I think guides a lot of my decision making. It's released a couple years ago. And, for cases like this where we have a hostile aorta, we've got bifurcation disease, extensive common and external iliac disease, I think the case probably for covered stenting, maybe even with CRAB technique, would be fairly strong for covered balloon expandable stents. As we get into the tortuosity of the external iliac artery, then you could consider covered self-expanding stents, but certainly most of us, I think, would be pretty comfortable using covered balloon expandable stents in this case, which is according to the guidelines. This is a case I recently did. So this was after a 6-0 balloon just to get the IVL across, and then treated it with IVL, and although it was covering the hypogastric, I ended up using a covered balloon expandable stent for this lesion just because of the circumferential ring of calcium on IVUS and how large the reference vessel was. I was able to post-dilate the front edge of the stent to help it match the common iliac artery. When I deal with in-stent restenosis, you can see there's a occluded stent there. The easier they cross, often the more worried I get about embolization. So if they're difficult to cross, then it's usually a matter of getting in a dissection plane and on either end of the stent, depending on how you're crossing it. But covered stents probably are the way to go for these, and that's recommended in the guidelines as well. Specialty balloons really don't have a role. Now, this does not include IVL, which was not really discussed a whole lot in the document, but certainly cutting balloons and cage balloons probably don't have a lot of benefit in aortoiliac disease, nor does atherectomy, as we just mentioned. So IVL, I think, is a little bit different and certainly can facilitate deliverability and deployment of stents, may reduce the risk of perforation, and I think probably all of us who use this note some more comfort with the procedure for the patient. Severely calcified lesions are generally going to be followed with a balloon expandable covered stent in my practice. And there's a nice analysis of the iliac treated in Disrupt P83, recently published, of 118 patients with 200 lesions. Nearly all of them were severely calcified. The IVL catheter is deliverable, and 73% of them underwent stent placement with no dissections or perforations. CRAB technique, which has been discussed this afternoon, is a relatively newer technique, although certainly the stent technology is making this procedure easier and easier. This is the same aortogram I showed earlier. So this is a 65-year-old guy who just had a large myocardial infarction. He's got an EF of about 10% and terrible rest pain that's only gotten worse as his EF has dropped, and he's got a severe lesion on his foot and is looking at amputation. So he's got a long external iliac occlusion, and so they're with the CT angiogram that we did before the procedure showing a long segment of hostile aorta. We ended up treating this with CRAB. And the patient did well with the procedure. It's a procedure that requires a lot of pre-procedure planning, but can offer really great results. And as was discussed this afternoon, it probably offers a little better geometry in the stent, particularly within the aorta, to reduce radial mismatch of the stents. So this was the case as it turned out. And managing aortoiliac calcification, I think really making sure I have more than one site prepped for bailout, aortic occlusion balloon handy, IVL, conscious sedation, and all the other knowledge about your lab equipment that Dr. Croissant mentioned is really important. So my iliac stent algorithm is really to consider suitability of endovascular approach. It seems more and more patients are suitable. I think if patients have severe common femoral artery disease and aortoiliac stenosis or in-stent restenosis with favorable operative risk, we consider surgery, but otherwise most of these patients do well with endovascular. Calcification, lesion length, and vessel sizing also play a role, and aortic involvement, we consider CRAB or other techniques instead of stovepipes, self-expanding stents, which don't work as well. So in conclusion, balloon expandable and self-expanding stents may provide similar results, each with advantages and disadvantages. Covered stents are preferred for complex disease. IVUS is really essential, and I think we're learning how important it is when we do these cases. IVL seems to have some utility, but there's really no role for atherectomy or other specialty balloons, and CRAB is preferred to preserve the carina over stovepipe self-expanding stents at the bifurcation. Thank you.